This is going to be the NRBS sponsor series, and we're happy to have you today. First, I would just like to mention with NRBS, we have programs that are very interesting. We have the NRBS sponsor series that you're a part of right now. We also have a CE series that's continuing throughout the year. And we have our podcast with Saul Rosenthal, the Healthy Brain, Happy Body. And additionally, we have our upcoming conference, our 2023 conference in October. That's the 27th and the 28th. So we hope that you could all join us then. And I would love to introduce Fred SHAFFER. He's going to be our presenter for today. Dr. Fred SHAFFER is a biological psychologist, a professor of psychology at Truman State University in Utah, and he's the president of AAPB. And he also has a company, BioSource Software, that's been around since 1978, if I understand correctly. Fred, I'll turn it over to you.
Thank you.
Oh, actually, as we're turning it over, let me ask people, as you have questions, we're going to ask that you put them in the Q&A, and going to hold questions until the end, of which we will have plenty of time to have your questions addressed and answered.
All right. Thank you so much.
You're welcome.
I want to talk about a new way of training clients to increase the healthy variability of their hearts. And this is called slow-paced contraction. This is APA compliance statement that you can read for yourself. This is just a real short summary of who I am. Here are our learning objectives. Explain the role of HRV in health and performance, describing resonance frequency and 0.1 hertz protocols in HRV biofeedback training, describing how to provide slow-paced contraction training, and identify situations where it may be more appropriate than slow-paced breathing to increase HRV. Here are some publications, one of which, and that's evidence-based practice, that should be available sometime in August of this year. This is a wonderful book by Dr. Ina Khazan that I recommend because of its practical applications. And this is one of our many products. We're very grateful to the late Evgeny Vaschillo, Branya Vaschillo, and Paul Lehr for their inspiration, encouragement, and support for my research team's studies, particularly on slow-paced contraction. And our first topic is HRV in health and performance. And for most of you, this will be a review. In 2014, my colleagues and I made the case in a review article that a healthy heart is not a metronome. We had to say it bluntly because the lay public believes that a healthy heart is a regular heart. This is healthy variability, as the time intervals between adjacent heartbeats are different. This is a heart where you have identical interbeat intervals, and this is a heart that may soon need a pacemaker. So unlike what lay people expect, equal intervals, the lack of variability is a very bad sign. It's either a heart that is on a pacemaker or a heart that will soon need a pacemaker. In our literature review, we found that heart rate variability is associated with so many things, what we call executive function. And so this is high-level cognitive performance, what we call regulatory capacity, which essentially is the ability to achieve and maintain homeostasis and health. And cardiac vagal control indexes how efficiently we utilize our very limited self-regulatory resources during resting conditions and when we're challenged, and then during recovery. Complexity is the key to our ability to maintain homeostasis. And the reason it's so essential to homeostasis is that it allows us to, with some agility, adapt to changing workloads in an uncertain and dynamic environment. The reason we care about heart rate variability metrics is that they are windows on our regulatory capacity, our health and performance, and even brief measurements may predict both morbidity and mortality. And by brief, I mean measurements as short as 5 minutes, although we certainly would prefer for predictive purposes measurements over 24 hours or longer. When I use the word vagal, I mean parasympathetic. Vagal tone adjustment helps us to maintain a dynamic autonomic balance, which is crucial for cardiovascular health. And of course, it's important for far more than just cardiovascular health. Imbalance due to deficient vagal inhibition results in morbidity and all-cause mortality. Now, there are two ways that we monitor heart rate variability, either in the clinic or the field. One method is the ECG or electrocardiogram, and you see that on the left, on the wrist. Another are infrared sensors. In each measures the time interval between adjacent heartbeats. Clinicians increasingly use HRV biofeedback to treat a spectrum of disorders, asthma, depression. Yes. And coaches provide HRV biofeedback to enhance performance in many contexts, such as musical performance and sports and dance. This is a wonderful review article by Paul Lehrer and colleagues. And what it showed was that HRV biofeedback produced the greatest effects on anxiety, depression, anger, and athletic and artistic performance. The weakest effect sizes were for PTSD, sleep, and quality of life. So those were the takeaways from a very influential systematic review by Lehrer and colleagues. Our second topic is the scientific basis of slow-paced breathing. Now, all of the sources of heart rate variability that we can measure in about 5 minutes are parasympathetic. That's a very important takeaway, that the sources that I will mention, respiratory sinus arrhythmia, the baroreceptor reflex, and the vascular tone rhythm, are all parasympathetic, and I will explain them in just a second. And so here's a graphic that just drives home this point. And respiratory sinus arrhythmia is at top because it's the most important, followed by the heart rate baroreflex. And then finally, the vascular tone baroreflex. And now let's unpack this. Respiratory sinus arrhythmia, also abbreviated mercifully RSA, is the healthy speeding and slowing of our heart rate across each breathing cycle. And this is the primary source of HRV. So look at the graphic below. And here we see the breathing cycle measured by a flexible band we call respirometer in blue. And here we see in red instantaneous heart rate. And we see that as you inhale, you get this speeding followed by a slowing of heart rate. This graphic was adapted from Elite Academy. Once again, blue represents breathing cycle. And notice that the interbeat intervals are closer together at the beginning because that's when we're inhaling and heart rate is speeding. And then as you exhale, there's greater spacing, meaning that heart rate is slowing. Now, inhalation partially disengages the vagal brake, and this speeds heart rate. And so that's why you see this rise here. And this is parasympathetic. And this graphic was adapted from a graphic by Dr. Richard Gevirtz. And so here we see the individual, the driver, taking the foot off the brake, and therefore heart rate speeds. And then as you exhale, you put the brake on, and now heart rate slows. Now, the late Yevgeny Vaschillo's two-closed loop model explains how both slow-paced breathing and slow-paced contraction can increase HRV. Vaschillo described two blood pressure regulation loops that we call baroreflexes, baro meaning pressure. A heart rate baroreflex and a vascular tone baroreflex. And what he suggested was that if you stimulate one loop, it activates its counterpart. And this is a, unfortunately, somewhat busy graphic adapted from Vaschillo's graphic. And what I want to point out is that you have a loop that controls heart rate and thereby controls blood pressure, and another one that controls the diameter of our blood vessels that we call the vascular tone control system. Collectively, these help us to regulate blood pressure. And I want to emphasize a very important point, and that is, while heart rate variability is desirable, blood pressure variability can endanger health. And that's the reason we have two control systems that help to regulate blood pressure so that it doesn't get too high or gets too low. Each of these control systems are potential targets for heart rate variability biofeedback training. Now let me explain the icons at the bottom. What we see here is breathing, lungs for breathing, and slow-paced breathing at a rate of 4.5 to 6.5 breaths a minute for adults is one way.
You might want to advance the slide. Is that the same slide that we're on? We're on two closed loop models.
Yes, and I'm explaining the slide to you so that when we get to the text, you can at least associate the concept with the icons. So you're looking at a graphic showing you the lungs, saying that we can manipulate heart rate variability through breathing, but then you also have an icon for muscle. And muscle contraction is another way that you can adjust, you can increase heart rate variability through the heart rate baroreflex. Now, this is a rate of stimulation between 4.5 and 6.5, either breaths or contractions per minute. On the right-hand side, you have muscle again, and this would be for contraction of muscles much more slowly than 4.5. It could be 3 times a minute or 1 time a minute. And this will stimulate the vascular tone baroreflex. So you can use breathing to control this system. You can use muscle through muscle contraction to control both. So each baroreflex is a potential target for heart rate variability biofeedback training. And you can, with slow-paced breathing and slow-paced contraction at 6 breaths or contractions a minute, either separately or synergistically, meaning you can combine them, stimulate the heart rate baroreflex. Or you can use slow-paced contraction at around 1 contraction per minute to just activate the vascular tone baroreflex. Once again, as a review, the heart rate baroreflex regulates momentary blood pressure changes to ensure stability and health. As I said, heart rate variability promotes health, but blood pressure variability endangers it. Now, the heart rate baroreflex exhibits resonance because it's a feedback system with a fixed time delay. And the time delay is due to the amount of blood in our vascular tree. The vascular tone baroreflex is all about the diameter of resistance blood vessels. And we're talking about arterial, small muscular blood vessels. And so larger arterial diameters mean lower blood pressure. In the graphic below, we have an arterial in red. Now, the vascular tone baroreflex has a 15-second delay. Its resonance frequency isn't 0.1 hertz, but rather 0.03 hertz. And what Vaschillo and colleagues proposed was that these two baroreflexes work together to regulate both blood pressure and heart rate. And again, to unpack the term resonance, this is an amplification process, and it's simple physics. An external force causes a closed loop system to oscillate with greater and greater amplitude at its resonance frequency. And here you see an external force potentially causing this glass to shatter. Ina Kazan has recommended a very pleasing image of a child on a swing. A single frequency of pushing the swing moves the child the highest and elicits the most squeals of pleasure. And the best pushing rate is analogous to the resonance frequency. And taller people and men have lower resonance frequency than women and shorter people because they have larger blood volumes. Resonance frequency and 0.1 hertz protocols teach slow-paced breathing. And people typically breathe 12, 20 breaths per minute. The resonance frequency is typically for adults much slower, 4.5, maybe 6 breaths per minute. And breathing can change blood pressure by altering pressure in the chest. And this change in pressure can stimulate the closed loops and drive RSA. Now, this is the impact of breathing on the baroreflex when you're breathing at normal rates between 12 and 20. So you're really not getting much variability in heart rate when you're breathing at somewhere between 12 and 20 breaths per minute. And in fact, you see these two waveforms, the baroreflex, and respiration as pretty much out of phase. The peaks don't align with the peaks, the valleys don't align with the valleys. But when you slow breathing down to the baroreflex rhythm, now you begin to align the peaks with the peaks. And now the heart rate swings, the peak to trough differences are so much greater, 4 to 10 times greater. So slowing breathing to rates between 4.5 to 6.5 breaths per minute for adults and 6.5 to 9.5 for children increases RSA. And this immediately increases RSA 4 to 10 times compared to a resting baseline. Increased RSA immediately exercises the baroreflexes without changing the underlying vagal tone or tightening blood pressure regulation. We adapted this graphic from Gewurz and colleagues, and now let me explain it. This is heart rate resting. So the person is just breathing at normal rates, is not receiving any feedback. And this is RSA, the changes in heart rate with feedback when breathing at, say, 6 breaths a minute or at your resonance frequency. It's 4 to 10 times greater. But the underlying vagal tone has not changed. The parasympathetic firing has not changed. That takes time. The advantage of resonance frequency protocols is to dial in the breathing rate to the rate that might be best for a given individual. As of 2023, the jury's still out whether this improves clinical or performance outcomes. So I definitely think of it like tuning in a radio station, as you see in the graphic below. The scientific basis of slow-paced contraction. One of the things I want to accomplish today is explain to you how to implement this in your practice. And here are some of the essentials. The client reclines with feet supported by a chair. And this allows them to rhythmically contract their hands, core muscles in the feet for roughly 3 seconds at a time at 1 or 6 contractions per minute. So let's unpack this. Person is sitting quietly with feet supported, ideally with the ankles crossed, and you prompt them to contract their wrists, core, and feet for just 3 seconds, either once or 6 times per minute. Now, the original Vaschillo protocol contracted wrists and ankles with the legs uncrossed. In our lab, we've observed greater swings in heart rate using wrist, core, and crossed ankle contraction. So here's a graphic, and you notice that the ankles are crossed, and the actual force of contraction can be very, very subtle. So we're not talking about a large contraction. We're talking about what Eric Pepper might call effortless contraction, about 70% of effort. Now, I'm going to throw some terms at you that you probably encountered before. Time domain metrics. So these are HRV measurements like the RMSSD. Tell us how much variability there is in a measurement period. Frequency domain metrics like low frequency power tell us how much power fell within a frequency band. If you've worked with neurofeedback, you will understand the idea that you can break a complex signal into different bands like alpha and theta and beta, and you can measure how much power you have in the bands. You can do the same thing with heart rate variability. Now, among the time domain metrics, one of the most intuitive is heart rate max minus heart rate min. And this is just the average difference between the fastest and the slowest heart rate during successive breathing cycles. And this is one of the easiest ways to index respiratory sinus arrhythmia. The RMSSD, which I mentioned a little while ago, is a mathematical equation, and essentially it's a square root of the mean squared difference of adjacent intervals. Arguably, it's the best short term, that means about 5-minute time domain metric, because it's less affected by extreme scores and artifacts than the SDNN. The SDNN is the standard deviation of sinus, meaning the sinoatrial node initiated beats, and it's measured in milliseconds like the RMSSD. In frequency domain metrics, we have the low frequency band, and it increases, power in this band increases during both slow-paced breathing and slow-paced contraction, and likely causes are baroreceptor and parasympathetic contributions. As of 2023, the consensus is that under resting conditions, you don't have a sympathetic component. It's all parasympathetic. And the term peak frequency simply means the frequency that has the greatest power. We talk about the peak frequency in the EEG as well. So here's a screen capture that shows slow-paced contraction that has stimulated the baroreflex at a frequency of 0.2 hertz when breathing at 12 cycles or contractions per minute, and 0.1 hertz for 6 contractions per minute. So this is 12 contractions per minute, which we don't recommend, but I want to use it for point of comparison. And so here we see that, yes, we're right on the money, but take a look. Heart rate max minus heart rate min's only 5 beats per minute. But let's instead slow it down. And now the person is contracting 6 times per minute. And now if you take a look, the maximum difference is 30, showing dramatically greater heart rate variability. Don Moss and Zachary Meehan and I compared 1, 6, and 12 contraction per minute, wrist, ankle, legs uncrossed, slow pace contraction. This is what we found. 1 and 6 produced greater time domain and frequency domain values than 12. And so we're talking about slow pace contraction. At this point, we were not studying the core. and we weren't crossing angles. And so this just summarizes. In terms of time domain measures, heart rate max minus heart rate min, RMSSD, and SDNN were greater for 1 or 6 than for 12. And in frequency domain, there was greater low frequency power at 1 or 6 compared to 12. And here is just another way of visualizing the data. There really wasn't any advantage or difference between 1 and 6, but a great difference between these and 12. And the same thing here. The same thing here. And here. In 2023, Zachary Mahan and I compared 6 contraction per minute wrist, ankle, and wrist core ankle with legs crossed, slow pace contraction against a control condition. This we found. Both of these slow pace contraction maneuvers produce greater heart rate max minus min and low frequency power than the control condition. The wrist core ankle method produced greater heart rate max minus min than wrist ankle. And so wrist ankle and wrist core ankle were superior to control for heart rate max minus min and low frequency power. And wrist core ankle was superior to wrist ankle for HR max minus min. In here are the graphs. How to teach slow pace contraction. I think it's important to avoid, and it's crucial to avoid artifacts that are produced by movement. And so while the HRV reader from our friends at Optimal HRV is put on the forearm like this is a terrible place to monitor the ECG if you're doing wrist, core, ankle. So what we recommend is a polar H10 just placed on the chest, and it's considered the gold standard for clean ECG recording. Now, here I want to take a moment and say that there are many good apps for teaching HRV. I'm very keen on the Optimal HRV application because it calculates the resonance frequency. It pairs effortlessly with its own HRV reader if you're using it for breathing. And it also has self-compassion and mindfulness training modules, exercises in its biofeedback suite. And Ina Hazan designed and presents these modules. And this is their reader, which costs roughly $50. So if you're doing breathing, it's a very affordable reader compared to, say, $110 for an H10. However, you don't want to use this if you're doing slow-paced contraction involving the wrists. So what I've suggested is you can repurpose the Optimal HRV application for slow-paced contraction training and just use a polar H10. Now, you can measure your client's resonance frequency, or you can skip this step and use, say, 6 contractions per minute. Here is a screenshot of the Optimal HRV app. You notice that you have modules for self-compassion, but you also notice down here that you could do resonance frequency assessment. And you could do that with the Polar H10 if you want to go that route. You select a new reading to calculate a pre-baseline. A pre-baseline is where a person's sitting quietly without feedback, without special instructions. You tell your client to breathe normally and sit quietly. And so here is the part of the menu where you see new reading. After the pre-baseline, go to the biofeedback menu at the bottom of the screen and select biofeedback training. And so you notice there is a part option in the menu for biofeedback training, and either select the 6 breath per minute option or your client's resonance frequency. So you have 2 possibilities. One is you can train at 6, or you can train at a resonance frequency, which might be at 5. And so you have these options, and you can choose one of these, and then you start the exercise. Set the timer for 3 minutes and enable track HRV and start the training. And so you notice that this is all set up for you at 5 per minute, except we're not going to use breathing. Slow pace contraction doesn't use paced breathing. So there are no special instructions for paced breathing. Instead, we're going to ask the client to contract the wrist, core, and ankles with legs crossed for 3 seconds at a time. And we're going to ask them to start 1.5 seconds before and end 1.5 seconds after each cycle's peak. So let me show you what that means. So the client's breathing normally. There are no special instructions for breathing. We don't care about breathing in this context. And so right before the peak of the optimal HRV display that it was designed to guide you in your breathing, we ask the client to start contracting. And at the end, 1.5 seconds after the peak, we ask them to stop contracting. So it's just 3 seconds at a time. In borrowing from my dear colleague, Dr. Eric Pepper, we encourage effortless contraction, which is to ensure a smooth rhythm and to minimize fatigue. So what we're thinking about is use 25% of maximum effort. You should feel as if your wrists, core, and ankles are contracting themselves. And so here we have a demonstration of what this is like. And we just go through 2 cycles of it just for a demonstration. When you finish a 3-minute trial, optimal HRV will calculate low frequency power, the RMSSD, HR max minus HR min, and the SDNN. And so this is the type of feedback you might have, except instead of 5.5 breaths per minute, it's 5.5 contractions per minute. And what I encourage you to do is coach and start a new trial. After 6 training trials, repeat the 3-minute resting baseline. So you start out with the resting baseline, you end with the resting baseline. And here are possible session activities. 3 minutes of discussion about practice outside of the clinic and progress as you attach the sensors. The 3-minute pre-baseline, no feedback, no slow-paced contraction instruction. They're breathing at normal rates. 6 3-minute slow-paced contraction trials as needed. And after each trial, you provide coaching. a 3-minute post baseline with no feedback or slow paced contraction instructions. Again, they're breathing at normal rates. And then you teach a practice exercise, ensure that your client can and will perform it, and assign 20 minutes of practice a day, and then have the grace to accept what you actually get. Here are training success indicators. Slow pace contraction followed the pacing display. The heart rate waveform was rhythmic and ocean-like. The heart rate peak to trough differences got bigger. Low frequency power increased and was around 0.1 hertz, or if you do it more slowly, around 0.03 hertz. Hand temperature may have increased, and skin conductance may have decreased if you monitor these modalities. And your client reports enjoying the training. Here's some difficulty indicators. And they're pretty much the opposite of what the success indicators were. Optimal HRV recommends that your client chooses a time that works best and starts out with shorter and gradually goes to longer practice sessions. So week 1, 5 minutes per day. By week 2, it's 10. By week 3, it's 15. Week 4 and after 20. And this it increases the likelihood of patient compliance. And practice can incorporate mindfulness training and self-compassion training, which are available within the mindfulness and biofeedback menu. Now, what if you're using a data acquisition system? You can use a multi-channel system, either using an ECG or PPG sensor, and you may also choose to use a respirometer, although breathing is not a component of slow-paced contraction. Here is a 6 contraction per minute Infinity training screen. So it's from Biograph Infinity, and a pacing display is center top. And so here, this would normally guide a person in breathing, but we're going to repurpose it for muscle contraction. So they will start about 1/2 seconds before the peak and will stop contracting about 1/2 seconds after the peak. Now, during slow-paced contraction, heart rate max minus min low frequency power will increase. But unlike slow-paced breathing, instantaneous in heart rate and respirometer waveforms will not be synchronous. You won't align the peaks and the valleys. So the peaks won't align with the peaks and the valleys won't align with the valleys between the heart rate signal and the respirometer signal. And again, a respirometer is just a flexible breathing sensor placed over the chest or abdomen. Without pacing or feedback, your client should breathe at typical rates during pre and post baselines. And again, typical rates are around 12 to 20. Obviously, if they are chronic pain patients, they may be breathing in the 20s. Now, with training, high frequency power, RMSSD, and hand temperature may increase, and skin conductance level may decrease. These are essentially the same success indicators as with using optimal HRV in a polar H10 sensor. And these are the same difficulty indicators, I do want to highlight something that we would see if we were using a data acquisition center, and that would show us power in the very low frequency band. And very low frequency power is being seen as a function of the older vagus nerve. So it's still parasympathetic, but it is not desirable. It actually is going to reduce HRV. So we definitely do not want effort to activate the unmyelinated vagus, the phylogenetically older vagus that actually could reduce parasympathetic activity. Now, very important idea. Improved vagal tone and blood pressure regulation, if that is a goal of training, takes time. Even though we can, within minutes, increase respiratory sinus arrhythmia, increase the large-scale swings in heart rate, to change the resting firing rate of the vagus nerve and to bring blood pressure under better control, this can take weeks to months of practice. And so I think of training providing initial physiological change, which can, over a span of months, improve health and performance, and during generalization and maintenance, which would be 2 to 6 months and longer, actually change the intrinsic firing rate of the vagus nerve. Here's a graphic that was shared by Dr. Khazan. And the big point is that high frequency power increased from the beginning of training to the end of training during resting baselines. Now, let me tell you why this matters. I know that if you have used HRV biofeedback in your practice, that during training, our focus is, can we increase low frequency power? And that's what we'd expect to see when people are breathing more slowly or contracting their muscles. But the real test as to whether training has been successful is what happens when the individual is now sitting quietly with no feedback, with no breathing or muscle contraction instructions. And we measure that in the high frequency band, because the high frequency band provides a proxy of vagal tone, but only when people breathe at normal rates without feedback. So with that, we see the pre-training baseline. So this is before any training was attempted. The person was breathing at 15 breaths per minute, and we see power spread out in the high frequency band. And it's never any higher than 100 microvolts. This is during the training session. And we notice that during a training session, we get the result that we expect, which is that there is an increase in low frequency power. And we see virtually nothing in the high frequency band. This is person breathing at 6 breaths a minute. Then finally, after many sessions of training, and now we're in a post baseline, we see that the person has increased high frequency power to 300 microvolts. And this is a proxy for increased vagal tone. Topic 5, When might slow-paced contraction be more appropriate than slow-paced breathing? You know from your own experience that slow-paced breathing can be challenging for patients who breathe dysfunctionally, for example, over-breathing. Chronic pain patients often breathe faster than 20 breaths per minute, and they may not be able to get down to the resonance frequency range, which can, for adults, is somewhere between 4.5 and 6.5. Some patients may breathe rapidly to protect their acid-base balance in disorders that cause a decrease in blood pH. Rapid breathing helps them to maintain homeostasis by expelling carbon dioxide from the body. Slow-paced contraction is safer than slow-paced breathing in metabolic or respiratory acidosis, where the rapid breathing is necessary to counteract decreased blood pH. In common metabolic acidosis causes are diabetic ketoacidosis, lactic acidosis, and kidney failure. Common respiratory acidosis causes are chronic obstructive pulmonary disease, asthma, pneumonia, and those neuromuscular disorders that can affect the muscles we use in breathing. There are unanswered questions that my research team is exploring. A research study that we'd love to give you an answer to is, does combining slow-paced breathing with slow-paced contraction increase resonance effects? We've collected the data. We have to transfer it. At the end of the last semester, we had malware attack our university system, and we had to shut down all university computers for the last 2 weeks. And so data collection is done. Data transfer will start when Truman resumes in a couple of weeks. We are interested in whether longer contraction periods than 3 seconds will increase resonance effects, and does greater contraction force increase resonance effects? And now, with some time left, I'm happy to take the questions that you may have put into Q&A.
Well, thank you so much, Dr. Schaffer. What a inspiring talk you just shared with us all. The first question we have here is from Patricia Dearman. Why low heart frequencies increase during stress if it is related to parasympathetic?
Actually, you're going to, okay. The concept here is that when we practice with too much effort, instead of activating the sympathetic system, we activate an older part of the parasympathetic system, and this in turn reduces heart rate variability. The very low frequency activity is occurring so slowly that it can't be sympathetic, which would be much more rapid. So Stephen Porges theorizes that what happens when we use too much effort is that we activate an older branch of the vagus nerve that doesn't contribute to heart rate variability. It actually reduces it. And this is a point that Gewurz and Lair have made more recently in their presentations, as we grapple with the question of what does very low frequency activity mean.
Thank you. That's a clear answer. Uldis Abele asks, do all the same principles apply to children, or have some nuances been taken into account?
we don't know. Our research and Vaschillo's research was done with adults. And so it's not clear what adjustments have to be made for children. And this is something I encourage you to discover in your own practices.
Thank you. Joe Didoro asks, is SPC a modified Valsalva?
Valsalva maneuver involves taking a fairly large breath and holding it. Slow pace contraction does involve some element of that, but it's more than that, especially since we're not just contracting the core, we're also doing the wrists and ankles, and you can obtain significant effects with just wrists and ankles without changing the contraction of the core. So I'd say that yes, we probably tapped into some element of the Valsalva maneuver when you go wrist, core, and ankle, but you can obtain some of these changes without doing that.
Okay, thank you. Alex Sanchez is asking, could this be helpful for chronic vascular insufficiency?
I have no idea. I try to be data-driven, and I have not seen any literature that has studied its effectiveness here. And so this would be experimental and would have to be presented to a client as something that is experimental.
Well said. Maritza Rivera Gaxiola asks, how do you achieve 6 contractions per minute without instructing slower breathing?
What you do is, what we do in our lab is we simply provide a display, and then the researcher gives a verbal prompt. So if we were doing this clinically, the clinician would give a verbal prompt. So you set the pacer at 6, but the pacer doesn't care whether you're doing muscle contraction or breathing. It's just counting time. And our instruction is simply to, if you're doing it at 6 contractions per minute, to start your contraction at the peak of 1.5 seconds before the peak of the pacer, and then 1.5 seconds after that.
Got it, thank you. Joe Didoro asks, can you discuss cerebral intracranial baroreceptors?
You know, that's above my pay grade.
Thank you.
By that, what I mean by that is the Vaschillo model really talks about general blood pressure regulation as opposed to systemic blood pressure regulation, as opposed to blood pressure regulation within cerebral blood vessels. And I honestly have never seen any literature, and it would be very specialized literature, that addresses that question in the context of heart rate variability training. So I'm not saying it's not an important consideration, but it's more specialized than, I imagine if you ask Paul Lair, he would say, that's interesting, now explain this to me. Tell me, in other words, it's a specialized literature.
Thank you. Due to time here, I'm going to move through this. Does optimal HRV show peaks in the different HRV frequencies?
No, it's not designed to provide fast Fourier feedback. But what it does, there are limitations to all of the apps that are out there. The limitations include, do they do any artifacting? Do they control for movement artifact? How well do they artifact? For what it sets out to do, it is a very well-designed app. One of many well-designed apps. Elite HRV is another. The Institute of Hard Math has wonderful software and affordable systems. And my recommendation is to not take my word for one, but rather to check it out yourself and see what is most intuitive for you and your clients. And Alexander, given the time and respectful of our attendees' time, if people would like to email me their questions that we didn't have time to get to, I'm a pretty quick correspondent. So I can be reached by way of the handout, the email address on the handout, by way of the Biosource website, and I'll be happy to answer questions. And it may be that the literature just isn't there, or it may be that I'm stumped, and I'll just tell you if that's the case. This is a relatively new way of increasing HRV, although it's been studied for decades. But the word hasn't really gotten out. And so the literature is just in its infancy. And there are a lot of really interesting unanswered questions.
Well, thank you so very much. It was a wonderful presentation, and thank you everybody for attending. Take care, everybody. Hope to see you at future conferences and webinars and the other sponsor series. Take care.
Right.